as many of you know, I'm Susan Muirhead, the support manager here at PKD Charity. I'm joined tonight by our CEO, my colleague Alison Taylor. Hi, Alison.
Nice to see you all.
And most importantly, our presenter tonight. You may have come across Dr. Matthew Gittis. Matthew is based in Sheffield and has kindly given us a few live sessions before. So thank you for joining us again tonight.
Good evening, everyone.
Just a quick roundup. We always like to know what's happening, what else is coming up. So upcoming events and information for you. For those who are perhaps in Scotland or wish to travel, we have a lovely information and support day in Strathclyde happening at the end of March. That's a Saturday. It's a full day talk event. The morning will be a mixture of presentations followed by workshops in the afternoon. Don't feel obliged to stay for the day. If you've got other commitments, you're welcome to drop in and out, but registration is now available and I'm sure that will get dropped into the chat. You may also be aware we have our PKD Connect support groups. These are small groups led by our volunteers who all have lived experience of PKD. We have quite a lot of them coming up throughout the country. We've got them coming up and you'll see the list there. I'm not going to read it off, but mostly you'll see there's a new one starting in Dorset in South Yorkshire, and that's starting in Barnsley. Dorset, there's potential of 2 groups, one in each side of the county. So if you are interested, I will share the link with you tomorrow for these, but I'm sure it will be also in the chat for you. And you'll also find them on our website. As you are in a webinar situation tonight, you are able to ask questions. You'll see on the screen, there's a little green circle. The green circle is around what looks like a speech bubble with a Q&A underneath it. If you click there, you are able to type in any questions you have, and Alison or myself will ask those questions once the presentation is finished. Quite often during the presentation, the answers will come out as Matt comes along, so we always wait to the end. This session will be recorded and it will be uploaded to our website. And again, we will share that link with you tomorrow or the following day. If you have any specific questions, please do email info@pkdcharity.org.uk. I have to do the medical disclaimer. We do have a doctor in the house. However, this is for webinars for information only. It's not a substitute for any professional medical advice or medical examinations. Remember to consult your doctor, your pharmacist, or any medical professional if you have concerns about your care or before taking any treatment. And again, we cannot recommend or promote any brands or treatments. So now what I'd like to do is we'll change over to Dr. Matt Gittis and his presentation, Understanding Blood Tests. There you go, Matt.
Perfect, thank you. I'll just quickly share my screen. 1 second. So thank you both for inviting me to talk today. I really appreciate another invite. I think it's a good sign if I keep getting asked back, isn't it? We'll go for that. And I'm really enjoying it, so I'm glad that there's a lot of people that have come to the session, and hopefully everyone leaves getting something out of it. And like we've sort of mentioned, I'm more than happy to answer questions at the end. I'll give you a caveat as I'll do my best. So if it's specific questions on very specific sort of details, it's tricky sometimes for me to answer without more information. But when we get to that, we can sort of cross that bridge when we get to it. So I'm going to be talking about understanding blood tests today. So the contents from this are from patients at Sheffield, so things that people have asked me in my training. So I'm currently a nephrology registrar, so I'm doing a PhD at the moment, but I do PKD clinics with Professor Wrong in Sheffield. Some other questions have come from the PKD Charity and questions that you've had yourselves that you've submitted prior to the session. I've got some more disclaimers. So there will be a focus on adults because I'm an adult kidney doctor. So I'm not trained in pediatrics. So there are some things that will cross across between adults and pediatrics, but the reference ranges will all be for adults. So if you're querying about children or about what the reference ranges in pediatrics are. I've not included them because I think they'll complicate matters, but the concepts will be the same, but the ranges might vary as well. The other sort of issue to sort of say is that when you look at your NHS app, because there's a difference in the lab reference ranges, there might be slight differences between the numbers that you see quoted as normal. But again, this is based on things at Sheffield, so it might vary a little bit, but again, concepts should be the same. And throughout the session, we're going to focus mainly on CKD, but there's additional context for people like yourselves or relatives that have got polycystic kidney disease that we'll cover as well. And like I said, more than happy at the end to ask any questions. It's going to be a bit of a whistle stop tour, but I think most of the time things like this are, aren't they? And then we can just cover things at the end if we need to. So this is the content. So firstly, why are there so many bottles? And what do these different bottles mean? Because this can give us a little bit of a clue as to what blood tests are being taken. Bit about how often you should be getting your bloods taken, and then understanding different types of blood tests. And then finally, the question and answer at the end. So firstly, why are there so many different blood bottles? So all the different colored blood bottles do different things. And when a GP or a kidney doctor or a different type of doctor selects the blood test, they all sort of code for different tests that they might be doing. So you might have a purple and an orange one, and they might every other time have a blue one or a pink one, and they all code for different things. So when they get sent to the lab, that's because they're testing for different things. So you can kind of have an idea of what they might be looking for based on the different colors. So first one's a purple lavender color, so that's checking the full blood count. So that's where they look for why someone might be anemic. The HbA1c is about diabetes, parathyroid hormone, which is a hormone involved in chronic kidney disease, in the levels get a bit high and a bit sort of unmanageable, which we're going to go through all these things. And then genetic testing is also on the purple one. So if you have a blood test with a purple one, these are the things that they might be looking for. More often than not, it's probably going to be the full blood count. The other ones are kind of additional ones that they might be doing time to time, but the full blood count is the sort of standard one. If you're having a yellow or a gold one, it's more than likely they're going to be checking your kidney function. They can also check for the CRP, which is infection marker, the function of your liver, bone, so that's calcium and phosphate levels, lipids, so that's cholesterol, and different vitamin levels would all be on that one. If you have a blue one, usually it means they're checking for your clotting screen, so to see how thick or thin your blood is. So that could be done pre-procedures. So if you're having a biopsy or you're having a line inserted, they might be checking that one, or any sort of if you're going to theatre, they'd be checking that one. Or if you're on warfarin, so some people might be on warfarin, they'd be checking your INR level. That would also be on a blue one. Grey one is there's not that many, so it's glucose and a few others, but for yourselves, glucose is probably the most relevant one. And then finally, a pink one. So they're checking a group and save, a cross match, or donor-specific antibodies. So group and save and cross match are both about whether you need a transfusion. And the donor-specific antibodies is related to sort of seeing how suitable you might be for a transplant. So you can kind of get an idea what blood tests they might be wanting or what they're wanting to find out based on what the colours are. So it kind of gives you a little bit of a clue. So if you go to the GP or you go to kidney doctors and they only do a purple one, they're not checking for your kidney function on that blood test because they can't. It needs to be the yellow or gold. So you can kind of get a vague idea of what they might be doing and why they might be doing it, which I think hopefully is helpful. I think it's helpful. I know people have asked me many times what do the colours mean and why they're having so many. And that's generally what it means. It means they're checking for lots of different things, and they're the sort of things that they might be checking for at the time. Another question I get asked a lot is how often should I get my bloods taken? And someone asked Susan this question before we started as well, so last week. So there's not any set rules, there's no set guidance on how frequently people should be getting the blood tested. But as a rough idea, if you've got normal quote unquote kidney function or mild CKD, so stage 1 or 2, or every 6 to 12 months, so probably more on the 12-month side. So if you're going to your kidney doctor once a month or once a year, and you get a blood test then, that's probably sufficient. If your kidney function changes and it gets more, it increases in its severity, so you're going to stage 3, then you might need it a bit more often. So every 3 to 6 months, again, probably more on the 6 months. And if you end up in the severe CKD, so that's stages 4 and 5, it's going to be more often than that. And how often, it kind of depends on what the sort of issues are at the time. So if you have problems with potassium, or it's rapidly declining, then they might check it more often than that. And it could be monthly, it could be every couple of months. But Usually it's sort of every 3 months is what I'd probably say. So when people are coming to see me in clinic, that's the sort of timings that we would give about how often they should be having it. Obviously, if you've gone to your GP and had a blood test, it's worth mentioning that to the kidney doctor at the appointment because they might be able to check that blood test and see have they done the things that they need to check. So it might save you having another blood test, which is important because it saves the veins. So if you in the future needed things like hemodialysis and needed access, it saves the veins on that side of the arm. So reducing the amount of scarring you might get from repeated blood tests. And also probably saves the NHS a little bit of money if you think about it. If everyone did that, then you might not need to do quite as many blood tests. And then there's more money for other things, which I think again is important, isn't it? So like I said, there's no set rules or guidance, but that's vaguely or roughly what I'd be sort of thinking when I'm seeing patients, how often they might need a blood test. So moving on to sort of the meat. So we're going to talk about the different types of blood tests and what the different things that people might be interested in whilst they're doing the blood tests. So the first ones are related to the kidney function. So urea is a chemical that's a breakdown product of protein that's done by the liver. And this is important because normally your kidneys will be filtering out this as a waste product. So it'll be getting rid of into the urine. So if your urea levels are high, it might be a sign that your kidneys aren't working quite as well as they should be. And there's no set number that we worry about. It's sort of more about symptoms than it is anything else. Oops. Let me just sort of move myself out of this corner so I can see the number at the top. So the reference is 2.5 to 7.8. So usually lower is better. So you want to be somewhere in the middle. If you're going above the 7.8, that's when we might be thinking your kidneys aren't working quite as well as they should be. And this is important because this is the chemical that makes people have a lot of symptoms when their kidney disease is sort of approaching stage 5. So when people are getting things like tiredness, fatigue, nausea, being sort of off their food and not eating very well, that's due to this chemical. It's due to the urea that's causing this. So and that's why people might choose to have things like dialysis is because the urea level is very high and causes those symptoms. It is affected by other things. So it's affected if you're dehydrated, the level of urea would go up. If you've got a very protein-rich diet, then the urea level will go up because there's more protein around to break down. And as a very sort of fine point, if people are having problems with gastrointestinal bleeding, that can also increase it. But that's separate to the creatinine, which we'll get onto. So, and that's because you've got like a blood amount of blood inside the body that's getting digested. So the urea level would go up on its own. So if you saw that, you wouldn't usually see the two not going up together. Usually you see urea go up and creatinine go up at the same time. If it's just the urea and the creatinine's completely normal, then it's a sign that maybe it's not the kidneys, it's something else that's going on. So speaking about creatinine, so that's the other one that sort of goes hand in hand. So you've got it's another breakdown product of muscles, and it's filtered by the kidneys into the urine. In itself, this isn't harmful, so people don't get symptoms from the level of this being high, but lower is better. Same with the urea. And it's made in the liver and it can be affected by lots of different things. So lots of the calculations use creatinine and they have to take into account if you're male, you've got a higher level of creatinine, certain ethnicity. So if you're black, then you've got a higher amount of creatinine than someone that's Caucasian. If you're older, that can affect it. So as we get older, we have a reduced muscle mass, so your creatinine level would be lower. If you have a high protein diet, again, like we mentioned before, high muscle mass for reasons other than age. So if you go to the gym, then you might have a higher creatinine level than you would do someone that doesn't go to the gym or someone that's less active. And then finally, if you're taking like supplements, creatinine supplements or creatine is sometimes what they're described as, that can also increase the level of creatinine. And that one's a tricky one. So usually I ask people not to take creatinine supplements because it just completely muddies the water. You don't know if is the creatinine high because of the kidneys or is it high because we're having more creatinine in the diet. And the sort of reference range is quite wide. And we'll get onto that about what the different eGFR means, because that's what creatinine is used to calculate. And you see there's a difference between the male and the female reference ranges. So eGFR and GFR. So GFR stands for glomerular filtration rate. E is for estimated. So it's very difficult to measure the GFR, the glomerular filtration rate because you haven't got a little computer inside the kidney to calculate it. You have to base it on different things. So the amount of waste that's being excreted through into the urine is how you calculate it. So the way that it works is you've got glomeruli, which are they've got millions of them per kidney, and then tiny blood vessels that are inside each of the kidneys, and they separate out the waste products and the excess fluid from the blood and then form into the urine. So the GFR is showing how well your kidneys are filtering the blood, and the way they work that out is how much blood is getting through in a minute. So this is what the GFR is, a glomerular filtration rate. So glomerular meaning glomerular life, and the filtration rate, how fast it's filtering things through the kidneys. So getting an accurate measure, like I mentioned, is very difficult. So we use estimated, and that uses the creatinine level and takes into account things like your age, sex, ethnicity to try and get a number. And roughly, I try to describe this to people as a percentage. So it's not technically a percentage, but I think that's the best way to think about it. So if you have an eGFR of 70, it's roughly 70% is how well your kidneys are working. And most blood tests that come back for eGFR will say over 90, depending on which calculation, but over 90 is what the vast majority of them say. And that's because above 90, it's very difficult to calculate them for certain the chemical that they're using for the creatinine to actually work out the result. So you can do it with other methods, but the vast majority of the methods that we use the creatinine. So it just says above 90 is normal, quote unquote. And that I think it was everything for, yeah. So I mentioned before about different CKD stages. So these are different stages. So if you've got an eGFR of 90 or more, you're CKD stage 1. So you've got essentially normal kidney function. And again, quote unquote normal, because normal's different, isn't it, for everyone? And 60 to 89 is mild loss of function, so CKD stage 2. 45 to 59 is mild or moderate, which is 3A. And then moderate to severe is 3B at 30 to 44. Then you're getting into more severe disease, which is 15 to 29, which is CKD stage 4. And then less than 15 would put you at 5, which is kidney failure. So these are sort of numbers to keep in mind. So in practice, we don't really use the kidney CKD stages. I think they're probably more useful to sort of view the number is how I view it. And I generally think people are better off thinking about it as a percentage rather than these discrete different stages. I think the stages are helpful for a sort of an overview. But if you said I'm in CKD stage 2, most of the time we don't even think about it like that. We'll just think about it as an eGFR. But it can be helpful to, I suppose, if you're thinking where you're going and how severe it is. It kind of gives it it's a good way to have it in the bins into different categories. But actually, in practice, we'll probably talk to you more about this is your eGFR rather than you're now in 1 going into 2. It tends to be a bit easier to think of it as a number because it's sort of a spectrum, isn't it? It's going all the way down rather than in these discrete little bins. And it's important to think about the eGFR because it can fluctuate over time. So on the left is a screenshot of an image from the PKD Charity website. And I'm just trying to show you that you look at the trend because that's more important, and you can actually have variation in the eGFR readings. It's very rarely going to be a very straight line going either across to be nice and steady or slightly going down or more severely going down. It's very, very rarely going to be a straight line. So it's important to look at the trends. You can't look at one-off reading. You have to look at least a couple. So 3 is how many we tend to look at to work out what the trend is and what's happening. And if you look at just a single reading, it's very easy to sort of be worried or alarmed. And I think that's understandable. But more often than not, we'll repeat that and see, is it part of a start of a trend, or is this a fluctuate within the sort of normal parameters, or is this a blip? So often we'll see like a blip and we'll repeat the test and it's a normal function the next time. And you don't know until you're doing the blood test for that. So it could be potentially biological or lab variation that can cause this, or sometimes if people have not drank quite as much on the morning of the blood test, if they've changed their diets or increased the amount of protein or done heavy exercise the day before, that can increase the amount of creatinine that's released into the blood. So it looks like the kidneys aren't working quite as well, but actually they are working just as well. You also get something called diurnal rhythm. So at different times of the day, you'll have different functions of the body, and at different times of the day, it'll be more active than not. So if you get the blood test done at different times of the day, you're going to get a different result. And finally, if you're taking a medication, the timing of the medication might influence what the creatinine is doing as well. So where possible, I always think it's easier if you get the blood test done at the same time, where possible. I appreciate it's not always easy as that, but where possible, get it at the same time of day, and then you sort of remove some of these issues. Again, sometimes I'll say to patients, if you are coming for a blood test, maybe don't have a really, really heavy red meat diet the day before, or don't go hammer it at the gym the day before, because it'll influence the creatinine result. Or if you're going to do it, at least tell us, so then we know what's going on a little bit. So I mentioned about sort of what can be called fluctuations. So between 5 and 10% swing could be considered normal. So if you had an eGFR of 70, that could mean you go down to 63. That could mean you go up to 77. So when I describe this to patients, I'll say your normal range is this to this. So for this patient, I'd say your normal range is between 63 and 77. So you could have any number within those amounts, and that is normal for you. Because you're within that 10 to 5 to 10% swing. If you go beyond that, then it's something that needs to be looked at. And like I said, most of the time, looking at it would be just a repeat blood test to see is this the start of a trend or is this just a blip or within the normal swing for you. And you've probably seen this slide before. So this is talking about how at the start, an early ADPKD, your kidney size will increase, but actually your kidney function's preserved for quite a while until sort of around 40 is where you might start to get a dip in your function. So you will have a normal eGFR for quite a while, and you wouldn't necessarily know unless you're having scans whether your kidneys are getting larger at that time. So I think it's something to bear in mind that if you're sort of in earlier in your disease process, or if you're earlier, it just being younger, then you might have a stable kidney function at that point in time. But as we sort of get older, the kidney function does drop normally, and it can drop sort of by up to like 5 points per year as we get older. So, but between people that have polycystic kidney disease, you can have different ways that it can decline. So in this example, again off the PKD website, PKD Charity website, you've got two people, Andy and Jen. So you've got people that are whose function is going down at different rates. For Jen's a little bit of an interesting one because Jen's function got a little bit better before it got worse. So this is in using a test that would find above 90. So like I said, most blood tests will just say above 90. But for these two, they've had a blood test that says above 90 and what their exact number is. So for Jen, she's actually got something called hyperfiltration. So this is where when you start getting a little bit of kidney damage, your kidney function can actually go up a little bit because the rest of your kidneys overcompensating and trying to pick up the slack even more so. So your kidney function actually looks a little bit better before it gets worse. Whereas Andy, he might have had that earlier in his life, but it's unlikely because he's at 20, but his function's declined a bit quicker than Jen by the looks of it. And this can be due to lots of different things. It can be due to environmental things. So if people start certain medications earlier, it can be due to genetics. So which variant people have inherited or just other genetics. So if people have had high blood pressure, then they might be a bit quicker. If they've had diabetes, they might be a bit quicker. So it's important to keep these things sort of in context, that the EGFR isn't just a number. It's sort of in what's going on at the time as well. It's important to say that it's unusual for you to have a sudden drop in kidney function. Polycystic kidney disease, ADPKD, doesn't often cause a very sudden drop in kidney function. So if your eGFR all of a sudden went down and very quick, then it's unlikely to be ADPKD that's causing it. It's more of a sort of slow decline over time, or relatively slow decline over time that you would be getting. So if it's a quick decline, it's more likely to be something else. So it could be a blockage. So if you had a kidney stone, that might cause that. You could have started a new medication that can cause a very sudden drop. Or if you've had problems with your blood pressure being too low, that could also cause a sudden drop. But if it's a ADPKD, rarely causes a very sudden drop. People asked about tolvaptan in the questions before the session. So tolvaptan, you start that based on your rate of decline. You don't base it on a single result. So if you had an EGFR that was on the lower side, you wouldn't necessarily think, oh, well, we'll start it now based on that one single result. It's usually done on the trend. So the criteria that we use for eGFR is a more than 3 drop every year for 4 years. And that's taking into account all those different fluctuations. So again, you're looking for a trend. You're not looking for a very single set result. And there are important to mention other criteria. So there's other criteria other than the eGFR. I'll very quickly mention about kidney length that's on an ultrasound and MRI and genetics. They're also their eligibility criteria. So someone might say to you, oh, do you want to start tolvaptan based on these other criteria? But for eGFR, it is a trend. It should be more than 3 per year for 4 years. Numbers to look out for. So these are numbers that I've got in my head when I talk to patients about polycystic kidney disease and CKD. So if you're sort of going just under 20, then I'd be thinking, oh, and you need to have a think about your options, because if this continues to decline, then you might need to make those decisions sooner. If If it's less than 15, I'd be saying, oh, you need to really have a decision now and sort of be preparing. So if you were wanting hemodialysis and you wanted a fistula, that's the sort of time you'd be thinking about that. Or again, if you wanted a pre-emptive transplant, that'd be less than 15. But the actual average starting point for hemodialysis in the UK is between 6 and 8. So these are numbers I've always got in my head when I'm talking to patients, because patients will say, oh, well, how long have I got? These are the numbers that sort of tell me how serious things are and what you should be doing at the different points in time. These are just from my head. So other people might have different numbers, other units might have different numbers, but these are the numbers that I constantly think about when I'm seeing people. And when I said about different options, so these are just in alphabetical order. So you've got conservative care, hemodialysis, peritoneal dialysis, and transplant. And for this, there's no right or wrong answer. And I think that's been discussed in a previous talk. But I think it's just important to say that when I talk about hemodialysis and peritoneal dialysis, that's not because they're a better option than conservative, transplant, or anything. It's just that these are ones that sort of have the numbers in my head. So moving on to the electrolytes and minerals. So you've got sodium. So this is what everyone thinks about when it's in salt. So salt is sodium chloride, and it's needed by the muscles and nerves to work properly, and it helps in how much fluid is in the system and what your blood pressure is doing as well. So it's too high is rarely the issue. If your sodium levels are getting too high, I'd suggest reducing salt in the diet. But you should be doing that anyway for blood pressure control. If it's too low, what happens, it sort of depends on the cause, really. So it could be that you've got too much fluid in the system, so you're fluid overloaded, and that makes the sodium look like it's lower than it is. It could be due to liver problems or hormone problems. They can always make it low as well. So being a little bit lower is not too worrying, and especially if you're low for a little bit low for a long period of time, that's not as worrying. What's more worrying is a sudden big drop. So sudden drops in sodium is where people come a cropper. If it's a low and it's been low for a while or slowly going down, people sort of accommodate to that and people get used to that level of sodium. It's even more dangerous if it's you suddenly went and treated it to go really high. That's where I'd be worrying about it. And tolvaptan, you check for sodium levels as well. So tolvaptan can cause high sodium levels just because of how it works, and that's one of the reasons why you're having a blood test every month for the first 18 months, and then every 3 months after that is to check on the sodium level. Potassium is another chemical that we sort of think about a lot for kidney problems. So the reference for this is 3.5 to 5.3. This might be different in different units, just very slightly again. But you need potassium for your muscles in heart. Too high or too low can be dangerous. Both aren't good. And as you sort of get more along the CKD progression, potassium can be a problem. It's usually a problem when you sort of in the CKD 4, 5, more often 5 than 4. And that's when you might need to do something about it. So when I say something about it, so if it's a little bit high, most of the time people will be asymptomatic. So 5.1 to 5.5, you might be asymptomatic, you might not really realize anything is wrong. If it's moderate, so it's 5.6 to 6.0, we'd usually say to monitor closely and then adjust your diet or adjust your medications. So medications like ramipril can put up your potassium level. So it might be you need to pull back on that and drop the dose a little bit, or start another medication like Lokelma, if people have heard of that one, to try and bring the potassium level down so you can keep on the ramipril. If it's severe and it's above 6, then it's an urgent review. That's when I'd be worried and I'd be saying you need to see either speak to your doctor urgently or A&E actually. Most of the time I'd be ringing people up and saying A&E, or at least speak to the renal doctor. When you've got high potassium, so dietary advice, and I'll get onto that on the next slide. Like I said, adjust the medications. Potassium binders are is the Lokelma. Some people are on Resonium or Patiromer. They're other ones that people can use. We can correct acidosis. So as your kidneys don't work quite as well as they used to, you can collect more acid in the system because it can't get rid of the acid. So correcting the acid can sometimes help with the potassium. If it's urgent, then it would be admission and into A&E or into a hospital for insulin dextrose with a drip and calcium gluconate, which helps protect the heart when your potassium level's high. And if none of that works, then it's dialysis, unfortunately. So, or conservative, we've decided you're not going to do dialysis. So high potassium foods, so these are ones that usually I say to avoid if possible. For me, it's not that you can never have a banana ever again. It's if you had a choice between having a banana and having an apple, have an apple. If you had a choice between, I don't know, chocolate and I don't know, I'm going to say a sweet now. I'm going to say Haribo, have a Haribo. That's the type of thing that I'd be thinking about rather than never have these foods ever again, that they're on a blacklist. Because I think that's really, really difficult, especially if there's a lot of these foods are hidden, like tomatoes are hidden in a lot of things, aren't they? Calcium is another chemical that'll be on this blood test. So calcium is needed for health of your bones, muscle, heart, blood clotting. And the level that we check is called an adjusted calcium level because it takes into account how much albumin, so how much protein you've got floating around in the blood. So the reference for that is 2.2 to 2.6. These can change in CKD because the kidney's doing lots of things with your calcium and your phosphate and the bone health because that's one of its main jobs. So you can have low calcium. So if your calcium is low, you might need to give some vitamin D or calcium supplement. It's very rare to give calcium supplement. If it's high, it's usually that you need to review medications and check your parathyroid hormone level. Phosphate's another chemical that we talk about a lot. So the reference of that is 0.7 to 1.4. And if you've got CKD, we'd really want it to be less than 1.8. But there is a caveat to that. So there's some debate in trials about how strongly should we be trying to bring it down below 1.8. And the trial's still ongoing, so I don't think the outcome of that's known yet. But phosphate in itself is helpful, but when it's too high, so normally the kidneys will be getting rid of it. If it's too high, then it can cause symptoms. So you can get itching, sore eyes, weak bones, muscle joints, and pains. So low is often not quite as much of an issue, but when it's high, you might need to adjust your diet, and we'll show you that on the next page. Might need to give you a binder. So there's different types of binder that you have with the mealtime and that attaches to the phosphate and stops it getting absorbed into the system, or we might need to look at your vitamin D levels. So these again are some of the phosphate foods, the foods that are high in phosphate. And again, I'm not saying never ever ever eat these things again if you've got high phosphate. It's about making choices between the two. It tends to be like nuts are very high, processed foods, so lots of preservatives are high in phosphate. Unfortunately, coffee, Diet Coke, normal Coke, chocolate, cheeses, all those sort of things. It's not necessarily the things that you think about, but these are sort of foods that are preservatives. It's quite a high one actually that you wouldn't necessarily really notice. Bicarbonate comes on this blood test a lot as well. So another job of the kidneys is to remove excess acid. So it tries to keep the blood slightly alkaline. So when your kidney function declines over time, so usually less than 30, the kidneys might not be removing enough of this acid. So what happens is the bicarbonate level gets used up. So bicarbonate does the opposite of the acid. It tries to neutralize things. So if you've got lots and lots of acid around, the amount of bicarbonate might reduce. We used to think it was really, really important to replace the amount of bicarbonate that people have got, but now the evidence for that isn't quite as clear cut. So some people might not reduce it, might not replace it until it gets down to less than 18. Some people might replace it if it's less than 22. I think it kind of depends on whereabouts you are in the UK as to how serious or how people view this. In itself, having a bit of a low bicarb isn't a problem. If you were having problems with potassium, then giving you some bicarbonate to replace the ones that's been used up can actually help with your potassium and bring it down a little bit. So that's the only caveat I'd be saying. If you've got high potassium, making sure that the bicarbonate level's okay is important. Other than that, it's maybe not quite as serious as we once thought. And there hasn't been any studies to my knowledge that have shown, well, there's not been any studies to my knowledge that have shown that having a low bicarb influences your health outcomes or kidney disease. What people ask a lot about is CRP, so C-reactive protein, and this is something that's produced by the liver, and it's a marker of active inflammation or infection. It's non-specific, so it doesn't tell us why you've got inflammation or infection or where it is. It just says that that's what's happening at the moment. It usually lags a few days behind you being unwell. So what would happen is you might be unwell and have a normal CRP, and a couple of days later, the CRP would be high. And the same on the flip side. So when you start to get better, the CRP might lag a little bit after by a few days. So you might feel completely better, but the CRP level will still be high. And CRP is relevant for polycystic kidney disease. So if you had a chronic cyst infection, you might have a high CRP. So normal CRP is less than 5. Again, a little bit higher than that. It might just say that you've got a bit of inflammation somewhere. But when you're sort of getting into sort of 50, or more than 50, like in hundreds definitely, then maybe something else is going on. And that'll be another thing to sort of speak to someone about. Vitamin D, so the kidneys normally help activate vitamin D from the sun. So what usually would happen is that in your skin, you have a type of cholesterol, and the sun converts this into vitamin D, but the vitamin D doesn't work like that. It needs to be activated first. So the kidneys activate it so that it can actually do its jobs and help for the bone strength and muscle health. So if your kidneys aren't working quite so well, you don't get as much activated vitamin D. So it's very common to have low levels of vitamin D. It's also common in the UK. We don't get that much sun. And lots of people work inside now, so it's very difficult to get enough vitamin D. So often people will have that replaced. So the reference for that is 0.7 to 1.4. But like I said, it's very easily supplemented. So you can either supplement it through tablets. Most of the time, I'd say get that over the counter if you pay for prescriptions because it's a lot cheaper over the counter rather than getting it through a prescription. And then diet-wise, it'll be things like oily fish, fortified foods, so certain types of bread have vitamin D in, depending on where you live in the UK. And then increasing sun exposure if you can. I think most people would like to. Most people go on holiday. It's a good excuse, isn't it? Get increase your vitamin D. Next thing to talk about is parathyroid hormone, which I mentioned earlier. So it kind of goes with the calcium and the phosphate and the vitamin D. They all sort of work together to make your bones healthy and strong. So parathyroid hormone is a hormone, unsurprisingly, that's produced by the parathyroid gland in the neck, and it helps control the calcium and phosphate levels in your blood. So it helps regulate things. So if you've got lower levels of calcium, then the parathyroid recognizes the problem and says, oh, we need to increase the amount of parathyroid hormone. And that's fine usually because it'll try and help balance things. But over time, that can become stuck and it keeps producing lots and lots of parathyroid hormone. And when it's producing lots and lots of parathyroid hormone, it's weakening the bone and it's not getting that balance quite right. And there's not a set number to treat. You sort of have to look at the levels of the calcium, the phosphate, and vitamin D and the parathyroid hormone levels together to try and work out what the treatment would be. But usually in CKD, we'd be saying it should be 2 to 9 times the upper limit of normal as a maximum, really. If it's any more than that, then that's when you sort of think, oh, this is going to be maybe affecting your bone health in the long term. And the treatment for that can vary. It could be that you need more vitamin D. It could be changes in diet. It could be certain medications. So cinacalcet is a medication that we use for this. Alpha calcidol is a medication we use for this. And in very rare situations, we might do a parathyroidectomy if none of these other issues have worked. So moving on to the next section. So we're talking now about liver function tests. So this is relevant for polycystic kidney disease if you're taking tolvaptan. Otherwise, ADPKD doesn't tend to cause problems with your liver function tests. It tends to affect your symptoms. So unlike the kidneys where it's affecting the kidney function, it doesn't tend to affect the liver function, but you can get symptoms from liver cysts. So some of these markers, so you've got the first two, so ALT and AST, so it's alanine aminotransferase and aspartate aminotransferase, and these are markers of liver irritation or inflammation. So if your liver's not very happy with these numbers that'll be going up, and reasons it might not be happy, it could be due to medication. So like I said, tolvaptan can increase your ALT, SAT. It could be due to a viral infection, so hepatitis viruses, they can cause this problem. Alcohol and exercise, well, if it's severe exercise can cause it, but it's not a reason not to exercise. Small rises are common, and these often spontaneously sort themselves. So a lot of the time, the first instance would be to just check it again. And if it's still high, then I'd be saying, oh, maybe you need an ultrasound to have a look at what the liver's doing. Is the liver healthy? Is there any problems that you can see on the liver? And then some blood tests as well to check. So you check for those viral things, look at the medication list, see if there's anything that's an obvious cause for why the liver might not be happy. If you have any signs of like a high ALT or AST when you're on tolvaptan, that's a reason we would stop the medication and then see what we do next. It might be that we restart it and see if it happens again. It might be restart it at a lower dose. It might be that we don't restart it. It kind of depends on how severe it was and how long it took to come down. But that's the main reason why you have the monitoring for tolvaptan is for the monthly and then the 3 monthly after 18 months is to keep an eye on how well your liver is functioning. Again, the references are up in the corner, 5 to 40. If I forget one, it's up in the corner every time. So the next liver function test I mentioned is something called alkaline phosphatase. So this is present in all tissues, but mainly it's in the liver, the bile duct, and also the bone. If it's related to the liver and the liver not working well, it's usually due to a blockage. So it'd be if you've got a gallstone, it might cause your ALP to go up. And the levels that for normal tend to depend on age, sex, and blood type, and that's why there's quite a big reference range for 30 to 130. So gallstones are common, mild increases are common, and it's often not that serious if it's a mild increase, and it often does spontaneously resolve as well. Bilirubin's the other chemical, the other level of the liver function test we check for. So bilirubin is what causes jaundice. So when people are yellow, it's the bilirubin that's high, and it's a sign of a liver problem. Again, it's non-specific. It's often normal when other LFTs are abnormal, so it's a bit of a funny one. It tends to be more severe liver function that it's high in. And the reference range is 3 to 21 for that. There's some people that have lifelong, very slight elevations of bilirubin. It's something called Gilbert syndrome, but it's quite rare that, and usually they're quite well, and it's a sort of genetic thing that they've inherited. But for most people, if you've got an increase in your bilirubin, it's a sign that your liver's not happy, and it might be seriously not happy. Moving on to cardiovascular disease and diabetes. So these are looking at the heart and your vascular health. So cholesterol is one that people ask a lot about and ask me when should we be having the cholesterol checked. So these are sort of guidance that I found from the UKKA about when to check it. So check it if you diagnose when you first diagnosed as CKD. Check it if you're over 40 or under 40 with other risk factors. So these other risk factors might be having a previous heart attack, having angina, stroke, diabetes, or being a smoker. They might be reasons why you're checking it. And there's different types of cholesterol. So in the top, you've got different levels and different types. So you've got good cholesterol and bad cholesterol. And you've got triglycerides, which is a type of fat. So all these together get added together into the total. So usually it's you might have a LDL versus HDL as well. And it's trying to look at all these numbers together to work out, is it possible to increase the amount of healthy cholesterol that you have, reduce the bad cholesterol that you have, or maybe you need a statin. And the monitoring for this is usually sort of say every 1 to 3 years. It's often the GP that takes control of this rather than kidney doctors, but I've done it and I've asked patients if they've been having the cholesterol checked and they haven't and checked it and started people on a statin. Statins are generally tolerated, but there are a couple of side effects to sort of be aware of, and it's probably worth speaking to the GP before you start any. They're probably keen for you to start on a statin because it reduces your risk of things like heart attack and stroke in the long term as well. So things good cholesterol versus bad cholesterol. So on the left, sort of a high in LDL, so the low density, and on the right, a high in good fats. So again, it's not that you can never, ever, ever have anything that's on the left-hand side. It's just if you had a choice between the left and the right, maybe go for the right. I don't want people to leave this thinking, oh God, I've got to have a horrible life or just eating really, really healthy forever. I think life's about balance, isn't it? So these are some guidance that's recently been published by KDIGO about ADPKD and cholesterol. So if you're 50 or older with CKD of any core, eGFR, they recommend a statin. If you're 18 to 49 with CKD, again, any GFR, then they suggest a statin if you've got additional risk factors. So those are the ones that we mentioned. So about a previous stroke, previous heart attack, angina, diabetes would be in there as well. Or there's a score that the GP will calculate to say how likely is it that you would have a heart attack or a stroke in the next 10 years. Those things might feed into it and suggest maybe having a statin. And then if you're already on dialysis, usually it's not recommended to have a statin. But if you are on a statin already and then go on to dialysis, then you might as well continue, is the view of it. There's no danger to having it. It's just the benefit of having a statin is less when you're on dialysis than it would be otherwise. Another one that we check, and this was again on that purple blood test, if you remember at the very start, it's called glycolated hemoglobin, so a HbA1c. So this is all about diabetes, this one, and the number determines whether they can diagnose you as being non-diabetic, pre-diabetic, or diabetic. So if it's less than 42, it's quote unquote normal. If it's 42 to 47, you're pre-diabetic. And if you're 48 or more, then you have a diagnosis of diabetes. And diabetes is one of these conditions that when you're diagnosed with it, you've got it and you can't reverse it. You can control it, but you can't reverse it. So in that pre-diabetic, you can do things that would mean that you're no longer diabetic. But if you've got over HbA1c of over 48 at any point, you are now diabetic and everything that you do will control it, but on your record, you will have diabetes. And HbA1c is a good way to check for this. It reflects your glucose control over the last 3 months. So the way that it does this is you've got hemoglobin, which we'll mention about on some of the next slides, which is inside the red blood cells. And if you've got lots and lots of sugar around in the system, that sugar attaches to the hemoglobin, and that's what this blood test is looking for. So lots and lots of sugar around attaches to all the hemoglobin, then you can detect it in the system. And it reflects 3 months control because that's how long a red blood cell lasts. So red blood cells last for about 3 months. That's how long their lifespan is. So after that 3 months, it won't be sort of registering it. It's only going to manage for 3 months is how long it's going to check. It's useful to check this as a baseline. So if you've got other risk factors, so if you're a smoker, if you've got obesity, if you've got a family history of diabetes or previous heart attack and stroke, they might be reasons why someone might check a HbA1c. It is less accurate in advanced CKD, so as you sort of approach kidney failure, HbA1c is not as accurate because the red blood cells don't last as long, they don't live as long. And also you might be getting things like transfusions or iron infusions or vitamin D replacements or vitamin B12 replacements that all sort of complicate matters a little bit, so it tends not to be as accurate then. Another way to diagnose diabetes is on your blood glucose level. And at the top, I've got a fasting and a non-fasting levels that are quote unquote normal. So they're different if you're fasting, so if you've not eaten anything, or if you're non-fasting, so it's a random blood glucose. And there's certain numbers that they can use to diagnose this. I think it's probably in time, considering the time, I'm probably going to skip past it. But there are different numbers that they can use to work out whether you've got diabetes based on your blood glucose level. The important thing is less than 39 means you're hypoglycemic. So when people sort of feel lightheaded and woozy because they've not eaten, that's because of hypoglycemia. Moving on to hemoglobin. So this is all about anemia and some of the other markers. So this is on again on that purple blood test. So hemoglobin is what's found in red blood cells. It carries oxygen around to all the tissues in the body. So if you've got CKD, this might be low because your kidneys are involved in the production of hemoglobin. So it produces erythropoietin in your kidneys, and that's a hormone that goes to the bone marrow and says, "Well, make more red blood cells." So if your kidneys aren't working in general, that affects the way that they're producing erythropoietin as well. So it means that they're not getting that stimulus saying, "Make more red blood cells." So anemia is rare if you've got an eGFR of more than 60. So if you're in CKD 1 to 2, then I wouldn't be expecting you to become anemic related to your kidneys. It's probably something else. If you're sort of going less than 30 to 40, then maybe it's your kidneys. It's important to think about anemia related to your kidneys as a exclusion diagnosis. So people should make sure there's no other reason for you to be anemic before saying it's your kidneys, because there's not a test that says, oh, kidneys are the reason why you're anemic. It's based on absence of any other reason. In ADPKD, hemoglobin is relevant as well. So if you had a cyst rupture or cyst hemorrhage, then you might have a drop in your HB, and it could be a bit of a bigger drop. And again, like I mentioned with the eGFR and with your creatinine, trends are more important than a set blood test, a set single reading. We tend to look at trends and see what's happening. And when people are anemic, symptoms are get quite non-specific. So it's tiredness, fatigue, not feeling quite right, might feel a bit short of breath or dizzy. They're the sort of things that people would be getting. Testing for this, so there is some evidence about how frequent to test. So if you've got normal kidney function or mild CKD, there's no evidence to say you need to have a routine check for that. If you've got moderate CKD for stage 3, then at least once a year, stage 4 or 5, at least twice a year. And that's because that's the point where you might need to be having erythropoietin, so the replacement hormone or something done about it. So reference range for this depends on whether you're male or female. If you've got CKD, we usually say it should be above 110-ish. You try to avoid it going above 120 because if it's above 120, there's some risks associated with that because your blood becomes thicker and stickier. So there's an increased risk for stroke and for heart attacks. So if you have anemia, so your HB is less than 100, the first thing that will usually happen is someone would check for different levels of chemicals or different vitamins to see, are you depleting these? Do you not have enough of these in the system? And it could be vitamin B12, it could be folate, it could be iron levels. And that can be replaced through changing your diet if they're not too low. If it's lower than that, you might need to have it replaced. So iron, you can replace it with oral. Oral doesn't tend to work quite so well if you've got CKD because you don't absorb the iron from the gut quite as well. So it might be that you need to have intravenous replacement of your iron. And then if that's not working, then and you're all repleting that, you've got enough of all these things, then it might be that you need to have something called ESA therapy. So it's erythropoietin stimulating agent. So that's things like I've forgotten the name, neorecormin's one of them. Or it could be that you have one of the new medications called PHI. So that's hypoxia inducible factor. This is going to test me now. Polypropylene hydroxylase, that's it. So one of them's an injection and one of them's a tablet, and that's to try and boost up the amount of hemoglobin. It's telling your bone marrow make more red blood cells. White blood cells, so these are what are involved in fighting infection. So if it's high, it's usually due to infection or inflammation. If If it's low, if you've got bone marrow's not working quite as well, or medications stop the bone marrow working as well. Certain infections can cause it to be low, and certain cancers can cause it to be low as well. I should have put also certain cancers cause it to be high. So it's all about infection and inflammation for your white blood cells. Platelets are how well we clot the blood. So if you cut yourself, platelets are involved in what's stopping the bleeding. So it can be high in infection, inflammation, iron deficiency, and your bone marrow not working quite so well. It can be low if you've got low production. So again, if your bone marrow is not working quite so well, high destruction, so it's been used up somewhere else, or if your spleen's not working quite so well. And then as a bonus round, so we're kind of getting close towards finishing time, is urine results. So these are things that we ask for when we're asking for your urine sample. We're not just checking the urine dip. So the urine dip will tell us things like pluses or traces or negative. So it could say you've got like a trace of blood, which is like a little bit, 1+, which is in a certain amount, 2+, more amount. And the same for protein. It might say you've got a trace, a little bit, and then more and more and more, depending on how many pluses. But these two tests I'm showing you now, so urinary ACR and urinary PCR, they're doing that in a bit more clever way. So if you've got healthy kidneys, your kidneys should be working well and they should be filtering out creatinine and it should be keeping the albumin. So albumin is a type of protein that your body needs to sort of move things around in the blood. So it should keep the albumin in the system and it should get rid of the creatinine. So if you have a high amount of albumin in the urine and a low amount of creatinine, it means your kidneys aren't filtering properly. They're leaking all the albumin out, but they're not filtering out the creatinine very well. And it's the same when you think about protein creatinine ratio, it's the exact same way. It's that if you've got high protein in the urine and low creatinine, it means your kidneys aren't working properly. They're leaking the protein out of the system and they're not keeping the protein or the albumin inside. So usually we say to do the ACR more than the PCR. And that's because it's more accurate and it detects more subtle changes, so it's more sensitive. And if you've got a level that's less than 15 or more less than or equal to 15, it's normal or low. If it's moderate, so 15 to 50, then it's a bit higher, and then severe if it's more than 50. So the treatments for this, it tends to mean that your kidneys aren't working quite as well. So it could be related to the stage of kidney disease that you're at, or it could be that we could give you certain medications to try and sort of fix things a little bit. So the way I sort of view it is that you've got a kidney barrier. I don't know if my screen's still on, but if you've got a kidney barrier and you've got holes in the filter system, that can make you leak all the albumin and the protein out. So if you give a medication like ramipril can tighten up the little holes and stop things leaking out quite so well. So people might start you on ramipril, they could start you on amlodipine that has a tiny bit of this effect for helping with protein, or there's another medication, the SGLT2 inhibitors, so empagliflozin and dapagliflozin, they can also help with this and sort of tighten up the kidney membrane so you're not leaking the protein. And there's evidence that these medications and doing this can help you stay healthier for longer, so it can delay the onset of kidney failure and also make you just healthier and have a healthier life and slow the decline in kidney function and push things like dialysis into the future. So it's last bit of practicalities. So I think it's important to look at your blood tests. My mum's got CKD. She's got the benefit of asking me, I suppose, but I tell her to keep an eye on it and look at the trends and make a note of everything. She's got it on her app, and I think that's a really good thing to do because you can look back. If your GP is refusing to do a test and you think you need it, it's probably worth speaking to the local kidney unit. I've written letters before saying, please, can you do a blood test to the GP? And then they tend to just do it. So that might be a way to get around it if you really want a blood test and they're not, and for some reason they're not saying it, especially if it's use and ease, because that's obviously a relevant one. Treatments shouldn't really be based on a single blood reading. So tolvaptan, I wouldn't be saying to do it based off a single result. I'd be looking at a trend. Sort of kidney disease and being a kidney doctor is all about trends. It's not about single one-offs. You can have recent illness or recent infection that can alter all these different ones and can make you have a little bit of fluctuations. It's always important to repeat that. So when you're better, you could repeat it and see is everything gone back to normal. And that might give you a bit of reassurance. And then finally, like I said, ADPKD rarely causes a sudden drop in your kidney function. It's usually a more progressive and sort of you could predict it. So you can see over time what would be happening, what the slope's doing. It would very rarely be progressing and then all of a sudden drop off a cliff. It wouldn't really be doing that. That's not normal. That shouldn't be ADPKD. That's something else, like I said, like a blockage or due to a kidney stone or sudden medication change or something. So this is just recapping what we've covered. So why there's so many different bottles. how often you should be getting your blood taken, and then we did a whistle-stop tour of the different types of blood tests. So kidney function, urea, electrolytes and minerals, liver function tests, cardiovascular disease and diabetes, hemoglobin and other markers, and then urine tests. So I'm happy to move on to the Q&A now, and I'll stop sharing my screen just so people can see me and I can see people.
Fabulous there. Before we go any further, there was one little question came
Yeah,
into the chat there that really caught my eye, and it's just for clarification. And as we
yeah.
always say, there's no such thing as a silly question. It was someone when we were talking about potassium levels, and they wondered if you have a normal eGFR, should you limit your chocolate, your potatoes, and your bananas, etc.?
You shouldn't have to, unless so. If you've got a normal eGFR, your kidneys should be working plenty to get rid of the potassium. So usually, it's if someone says to you, "Oh, your potassium's creeping up a bit," or if I was a patient and I knew that I was approaching things like dialysis, I might keep a bit more close eye on it. If you've got a quote unquote normal eGFR, eat as you like, within reason.
Perfect. And someone else, and again, it's one of those odd questions, but someone's thought, so we'll
Sure.
ask it. Does a lady's period affect blood test results?
So it definitely can affect your hemoglobin because obviously from blood loss. I think I'm not sure about it affecting eGFR and your kidney function, but definitely hemoglobin, definitely clotting it could do as well. But I can't think how it would affect kidney function off the top of my head. I'd have to have a think. I could have a think about it and get back to you, I think, on that.
I think questions are coming in fast and furious. Alison, have you managed to have a look through them?
Yes, I spotted somebody asking when you were talking about trying to not have too many blood tests and trying
Yeah.
to do more than one at once if you can. Somebody's asking, so how much scarring can be caused by repeated blood tests? Say blood tests every 3 months. Could this affect a fistula?
Yeah, so you could do. So what I tend to advise people is to go for. So if you think with a fistula, you tend to have a fistula on your non-dominant hand or your non-dominant side on your arm. So if I'm right-handed, I'm probably gonna have a fistula on my left side. So I'd be saying, can you do the right side? I'd be going for my dominant arm. And there isn't. I don't know if I'm aware. I'm not aware of any research that says how many blood tests are too many. But if you can avoid it, I think it's better to avoid it. I don't think anyone's going to be able to say this is the optimal number of blood tests, but I think if you have a blood test for a GP and it's within a month, that's probably fine, unless you're going to be checking for something else. And I'll see patients that have had a blood test with a GP a couple of weeks ago, and I'll say we don't need to repeat this because it's not going to change what I'm doing. I've already seen the blood test. But the caveat about this arm dominance is probably a relevant thing. If you're thinking, oh, I might need dialysis in the future, oh, I might have a fistula, usually that's put onto your non-dominant. So if I'm right-handed, it'll be my left arm is where the fistula is. So have your blood test on the right arm.
Okay, that's great. Somebody else has
Uh,
asked why some tests require you to have fasted and others don't.
Yeah, so glucose is because say if I just ate a donut or ate something now, there's so much glucose just related to that blood test. So that's why the fasting will make a difference for that. Other
Okay.
ones, there's not that many that you'd be fasted. So there's a couple of like cholesterol ones that sometimes you might do if you're doing a special test, but mainly it'd just be for the glucose. Because if you have a sudden meal related to it, your glucose level will spike, and it's not really measuring what your glucose levels are normally. It's just measuring what happens after you eat a donut or a biscuit or something.
Susan.
one that's a rogue blood test, and we know they do crop up. The patient here, I'm post transplant and seem to have had a recent problem with a rogue antibody in the last 6 to 9 months. I'll be having HLA test each visit. Can you explain the printout just a little bit about that? So it's looking at HLA tests
What was
for a
this?
rogue antibody for someone who's post transplant.
So when they're doing that, so when you've got antibodies, these antibodies can come from lots of places. It could be from the kidney that's been transplanted. It could be if you've had a transfusion. It can, if people are pregnant, they can have an antibody that comes a cropper. When they're checking it once a month, they're seeing has new antibody came up, and it can be a sign that maybe your immunosuppression is not quite as good as it could be because it's allowed this antibody to kind of slip through and develop to it. It's probably outside the timing and in the scope to explain how all the HLAs work. Could ask me back for a transplant one, and I could try and do a transplant one, but I think it's probably a bit too complex for me to go in the amount of time we've got, I think, unfortunately.
No, that's
We
fine. Thank you for the honesty in that answer. We spoke earlier about the variations from one day to the next when bloods are taken. You've said hydration, what you've eaten before, etc., can impact on these. Someone's mentioned that they've had 3 tests, October, January, and February, all in the afternoon, and their function has dropped 9% in that time. Should they revert to morning appointments to see if the results differ?
I think if you've got those three and it's been a persistent drop, that probably means it's a persistent drop, I think. Reverting to a morning, probably it might make it look a bit better, but ultimately it sounds unfortunately like things have progressed and your kidney function has dropped. So changing it to a morning might just complicate things. I think it'd be better to stick with the timings that you're doing. And again, like I said, it's an ideal situation. Like it's not always easy to say, oh, I'll have a morning appointment and an afternoon appointment, but it can explain a little bit of the variation. But if I'd seen from October, January, February, and it was a persistent drop of 9, it makes me think you've got a persistent drop of 9 rather than needing to change when the blood test's taken.
Alison?
We've got a variety of other questions
I
here,
know.
and some of
Good.
them aren't all on topic. So we will try to get back to everybody who's asked a question that isn't quite, we're not going to be able to answer this evening. Somebody has asked that they've been put on a potassium binder, K-exolate, and they understand that this can increase sodium amounts in their blood.
Yeah.
How much could it increase the sodium level? I'm not sure if that's too specific or.
Yeah, so I don't know what Kexler is. I think that's a brand that I'm not familiar with. Usually we don't see the sodium going up that much, and I think the balance of the sodium going up a little bit versus the potassium being bound is much more in the favor of binding the potassium. Potassium's going to kill you by the potassium being too high because it affects the way that the heart works and can make people have heart attacks. So potassium's the thing to worry about. Sodium maybe not quite so much. A bit high sodium over isn't that concerning. And the way to sort of mitigate that would be reducing the amount of salt in your diet if you know that you're having this medication that's got sodium in it.
That's
And just when we were talking about high potassium, someone asked, is there any symptoms when we have high potassium?
Unfortunately, not really. So if your potassium is very, very high, people might get palpitations or they might get angina type symptoms. But other than that, most of the time people wouldn't know. It's a blood test is the way to sort of find out about it.
Well, somebody has said a huge thank you to you, Matt, for your talk this evening, and that preempts us to do exactly the same. It's always great when you come and talk to us and you explain everything so well and so clearly. So we want to say a really big thank you to you for doing that this evening.
All right. Good. I enjoy it. I think hopefully that comes across. I enjoy doing it. Even though it's a lot to fit in a small amount of time, but I do enjoy doing it.